Well, welcome everyone. Welcome to our live audience here in the theatre at Questacon. It's a great event that we've got planned today, and there's a little bit of pre-briefing information that we have to give to the live audience and also to the schools across Australia.
So the first thing we'll do is introduce ourselves. My name's Priyanka, and this is Robert.
I'm Robert.
Now we do have quite a few live schools here, so I'm just going to read your names out, and when I say the name of your school, I want you to give me a big whoop so we know where you are. All right. Bergman Anglican School. Excellent. Gungahlin College. Marici College. Talopia Park School. Brindabella Christian College. And Queanbeyan High School. Brilliant. Welcome everyone.
Fantastic.
Oh, who did I leave out? Oh, sorry, my bad. Melba Copeland. Sorry, guys.
Excellent. All right, now, hanging off the end of our video line here, we've got a number of schools right throughout New South Wales. So I'd like the school's intern, when I mention your school's name, to unmute your microphone and give us a shout out so that we know that we can hear you and you can see us. So we're crossing first to Katoomba High School. Fantastic. Great to have you with us, Katoomba. Now, we'll have you, as with all the schools, having your microphone muted so that when you are participating in the question and answers, you can unmute your microphone and ask your question. But until then, if you can keep your microphone muted. So the next school in New South Wales that we're crossing to is Balgowlah Boys Campus in the northern beaches of Sydney. Unmute your microphone, give us a shout.
Good afternoon. Hello.
I know it's only a small group there, but this is important.
Oh, Jim.
There we are.
Who's this big kid from the right?
Karingal High School. Karingal, can you unmute your microphone and give us a shout out?
Hello.
G'day, and welcome to today's session. There you are. Okay, and we really encourage all of you schools to think of questions as we go through today's session so that when we cross to you, you're all ready.
Viewing schools.
And then we've got two other schools which are on the line but are not interactive. So we've got Hay War Memorial School in Hay in Western New South Wales and Boggabilla Central School. So welcome to both of you to this video conference. We also have a connection to the Charles Darwin University up in Darwin, and we've possibly got students from two universities, from Charles Darwin and possibly also from Flinders Medical School in Darwin, and we also have in the room some students from the Kumilda High School. So if you could unmute your microphone and give us a shout out and let us know. Excellent. Nice to see you up there. We hope it's nice weather up there, and I believe that there's just a few technical issues with the transmission of the information from Darwin, so we'll just have to work our way through if there's any dropouts in the audio or in the video. But we understand what's going on, and I'm sure that you'll be able to interact very well with us. Okay, Pri.
Now there's a few partners that make this possible.
Yes, indeed. In fact, this video conference is being brought to you by a whole range of institutions. There's Questacon, which is Australia's National Science and Technology Centre, but we're working with a whole range of partners. The first one is ARNet, which is Australia's Academic Research Network. They run a broadband network that links up all the universities and research schools across Australia with extremely high-speed transmission of data. And they're hosting down in Melbourne this video conference for us. So thank you very much to ARNet. We also have well, in fact, Dr Wood is brought here by Inspiring Australia, the Commonwealth Government program for inspiring Australians about the importance of science and technology in our everyday lives, in our economy, in our social settings. So, Inspiring Australia, and also by CSIRO Discovery, which is the Science Centre here in Canberra, where a lot of research and a lot of educational outreach happens to Australians. And we also have a whole audience that we're not sure how many there are, but we're streaming this video conference twice. ARNet is streaming it to the internet, but also the Royal Institute in Australia, which is actually in Adelaide, is also streaming and receiving this feed. So we know all the audiences that we've introduced, but there's a whole stack of other people who are also looking at our presentation today. So welcome to everyone in our remote audiences.
Excellent. Now, before we introduce Dr Fiona Wood, we've actually got a doctor here at Questacon. So I would like to welcome Questacon's resident doctor, Dr Scar. Hello, Dr Scar. How are you?
Hello, I'm good, good. Hello, everybody. Nice to be here today. Now, for those of you not quite sure what I'm doing, I've got a microphone. It's very exciting. Is it on? It's not. Oh, there it is. Hello. I can hear you. All right, I am, as said, Questacon's resident doctor. I actually like to talk about all the science of scars and bruises and injuries and all sorts of gross and disgusting things while using special effects makeup to actually make children look like they've been horribly disfigured, which is tremendously popular. Right.
Now, I believe, Dr Scar, just from that blurb that you just said there, sounds like you like hurting children.
Oh, it's completely true. Children these days are far too nice. Oh, look at me, I've got a ribbon. I've got curls. It just makes you sick. So part of what I'm doing is just helping my sense of inferiority by making attractive children not quite so. I think that's quite beautiful. Now, I do believe I've got a couple of volunteers up here. Brooke and Carly, I'm actually going to do some intensive work, and we're going to make you look disgusting.
Can we please give our volunteers a big round of applause? Come on down.
I'll be checking in a bit later on. You can continue.
Excellent. Now to why we're all here. Please give a warm welcome to world-renowned burn specialist, Dr Fiona Wood. Dr Wood, so can you tell us what you're doing in Canberra?
Well, inspiring Australians, I hope. Coming here to talk about some of the things that I do in my working life and how science is pervasive. It's all around us, and certainly all the science and technology I use on a daily basis to help burns patients.
Excellent. Now, I believe you have a bit to tell us about burns.
Yep.
So take it away.
Fantastic. Thank you very much indeed. And thanks for all coming along today, because you all must be budding scientists, technologists, and hopefully I'll give you some kind of food for thought today, because I reckon you're the future. So let's start with, oops-a-daisy, the right PowerPoint, and start with skin. I could talk about skin for days and days and days. Skin is exquisite. It is an amazing organ. It does all sorts of things. You know, it's a refrigerator. It tolerates our temperature changes. It actually alters our vitamin D content. It's sensitive. It's a giant receptor. And it does its own running repairs. The fact that it can regenerate all the time. As you're sitting here, your skin is regenerating. It takes about 6 to 8 weeks to replace the skin surface, just continuously. A bit more aggressive and a bit sort of plumper, I guess, in the youngsters amongst us. Those older ones, it starts to get a bit slower and a bit more wrinkly as we go on. But essentially, the skin is a very dynamic organ. And so if it's that good, why does it scar? Look at this, if you look at the histology of skin, I could talk about it for days. It's got lots of different things in it. Sorry. Where are we? Lots of different things. The hair follicles, the sweat glands, the arteries, the veins, the waterproof layers that keep the water out and the bugs out and keeps the water in. When you start to lose skin, when you get burned, you're a leaky sieve. But I'll kind of come back to that. This is what happens when you get burned. This is a kiddie I met in 1985. And this is from a cup of coffee. And you think, whoa, you know, you hear those things, hot water burns like fire. Well, it does. This is a child who came to the place I was working as a plastic surgery youngster in training. We've healed the wound. What about plastic surgery to fix it? That scar is for life. That child will never move their neck and arm the same way on that side. And it was really defining me at the time, thinking, whoa, if this is the best we can do right here, right now in 1985, we've got to think about how to do better. We've got to think about regeneration. And when I start to talk about regeneration, you think, well, why can lizards do it and we can't? If an axolotl loses its tail, it grows it with the spots in the right place. That is fantastic. Where along this evolutionary pathway have we lost the ability to regenerate beyond the minor injuries? I've told you, your skin's turning over the whole time. But it doesn't take much to overwhelm that regenerative capacity and push you down a scar path. I mean, Dr. Scar's making some right now as we speak. So where did we lose it? It may well have been for a very good reason. You can imagine. We don't want to shed our body parts as we go around the footy field, but we've got to be able to understand the powers of regeneration in order to drive forward into the future. And this is kind of where you guys come in. This is 100 words I had to write for the Medical Journal of Australia on where I thought burns would be in 50 years' time. So what I want you to imagine is like a giant car wash. Okay? And in the first part of this car wash, as you're going through, you're going to do the assessment. The assessment is key to injury. I want to know what's wrong. I want to know what's wrong with this whole body. And then I go into the next part of this car wash, and then I'm going to remove all the stuff that can't be salvaged. I want to remove that, get rid of it. And then in the third part of the car wash, I want to rebuild. And that's the exciting part. I want to rebuild this person, and I want them to be exactly the way they were before. I want to regenerate, not scar. But to do that, as you can see, tissue all the way to solve the clinical problem of multidisciplinary scientific approach is needed to ensure the quality of the scar is worth the pain of survival. Burns are painful. And so in order to do all this giant car wash, we need a lot of heads. We need a lot of energy. We need a lot of problem solving. But interestingly, we've already started making progress. Progress that you guys can build on into the future. So let's go back to the first part of the car wash, where we're going to look at the assessment. What about things like, we want to multi-scale. I want to look at it. The first thing I do when I look at somebody is as I look at the normal skin, the abnormal skin, how different is it? Is it charred? Is it wet? Is it black? Is it white? I'm looking at all these things in my mind. I was with the computer scientists who were talking about artificial intelligence and assessment. Ooh, I think our boiling water's boiled a bit quick. I don't want to burn myself. Talking about this artificial intelligence, how was it as I walk along the corridor and I see a child with a burn on the face from a hot iron that's fallen on that child, and I've walked on by, I've spoken to the nurse and told her what dressing to put on it in that eyeful. What is it about that I can connect with the experience of 20 years, which is a bit sad, and say, right, that's the kind of dressing that kid needs in order to not scar. So how can we get that in computer systems such that we can assess wounds on a regular basis and remotely via telehealth? So all the way down to things like confocal microscope and synchrotron technology. So we not only look at the person macroscopically, the whole person, then we focus in. We focus in, looking at that burn. I know that the palm of that burn is full thickness injury. I know that the parts of the dorsum here are partial thickness. I know I can salvage the deeper layers here. I can't here. And so how do we look at that hand and then look down into this other gentleman here and look down and use scanning technologies to see the depth of the injury, the extent of the injury, all the way down to how the cells are affected. Are they going to go down the path of programmed cell death, or will they be salvaged? All the way down to the proteins and the genetic makeup of that individual, the regenerative capacity of you, your wound, your cells, your genes, and then pull it all the way back and say, right, now we've got the information, we can move on. And we can move on to debridement, the second part of our car wash. I know that the burn wound is like a massive abscess. If you've got a big abscess, with a little bit of pus in it, you put a knife in it and you let it out. And that will save a life, or it'll save a lot of pain in a small one. But with a burn, that tissue is dead. It can't be salvaged. The certain areas can't be salvaged. If I don't remove it, it forms an opportunity for bacterial invasion, and infection is the biggest problem we have in burns. In fact, we say we want to close the wound as quickly as we can while the waves of infection keep coming over. And we want to treat those infections, and bat them back, and sometimes we're not successful. So infection is the biggest problem we have, it's the biggest killer, but it also leads to worse scar, because it just nudges the damage goalposts further and further and further. So, what I do right now is I get a sharp knife and I cut it off. And I cut it off to the point of bleeding, because then I know it's alive. That's subtle, isn't it? You know, and so, can we do better? Well, I think so. What about autolytic inflammatory control techniques, enzymes that can actually guide our level of debridement? What about image control, so that we've got histology, actually microscopic, real-time histology on our knives? Wouldn't that be cool? One day, guys, I want one of those, so the tech heads amongst you. But what about this is it? This is what we do. We think, oh, I've just said I debride with a sharp knife down till it bleeds. That looks nice. To me, that looks clean. It's fresh. It's white. I know it's alive. But it's not bleeding. It's got a tourniquet. They see that? There's a tourniquet, because if I let that tourniquet off, they would lose their blood volume very quickly. So I can only let it off for a very short time and put it back on. So just test that I'm at the right depth. And then we put the skin grafts on. As you can see, we've tested that we're at the right depth, and we've put it back on, and we've moved forward. But you think, where do flies come in? Now, flies, the maggots, I should say, that come from flies, in their saliva, have got an enzyme that can tell the difference between tissue that's dead and alive. Now, that is fascinating to me. The French put maggots in tea bags, and they put them on wounds, and the enzymes come out of the tea bag and dissolve the tissue on the wound, and they wipe it off, and then it's all here, it's all ready to put the skin grafts on, or whatever you want to do to heal the wound. It removes the tissue that is dead, but leaves what is alive. Now, there's an awful lot we can learn from that, because that becomes a lot more subtle than a sharp knife. Salvaging those tissue frameworks so I can reseed them. There's a group in Israel that have produced an enzyme that's not quite as good, but it's moving in the direction that comes from pineapple, in fact. So we can start to think about how we can do things better, more subtly. Remove this dead tissue that is going to cause you a problem, and it causes that inflammation that causes the problem as well, but retain everything that is you, because you are special, and it's hard to replace. So we need to understand this life cycle and understand the enzymes there. And then we come to the exciting part, the car wash. Already we've probably used up a significant amount of the sort of grant funding in Australia to get to our third part of our car wash. But here we are. We're into reconstruction. We're into tissue-guided regeneration, self-assembly nanoparticles to provide frameworks to guide cells express the appropriate phenotype. A phenotype is the cell characteristics. And we've got the same genetic material in all our cells. Well, why is a liver cell and a brain cell and a skin cell different? Because of their phenotype. So what I want is not a scar phenotype. I want a skin phenotype, normal skin phenotype. So how do I guide that in my reconstruction? Where do the cells come from? The cells come from two places, locally and in the bone marrow. We know that cells in the bone marrow can produce cells that will go into all sorts of tissue. That's our stem cell source. In fact, when you really aggressively exercise, the number of stem cells in your blood, in your circulating in your blood increases. Maybe that's why you start getting bigger muscles. We don't know, but you can see the cells are there and they start to circulate. What makes them land in a certain place and facilitate healing is another story. This is a cell that's in our lab, and this is a skin cell. It's a keratinocyte, and it's crawling across a nanoporous membrane. These nanopores are all really finely controlled by the pH and the electric current to give a different size. And we could change the size of those holes, and the characteristics of the cell will change. So we can change the phenotype of the cell by changing the environment it's in, guiding it towards the skin phenotype away from the scar phenotype. A lot of my life has been spent looking at spray-on skin cells. And so we're going to show you a little video now of how it's done. Because basically this is a technique where we take skin from your normal skin, an area where you're not injured. So if, my wound's over here, I take it from and try and take it from a matched site. Because our skin is different all over our body. The palm of my hand is different from my eyelid. Getting an eyelid to scar is quite hard, but getting this area of skin not to scar is very hard. So the scar potential is different on the body, the skin is different on the body, and here we've got the skin, and we're putting it in an enzyme. That's the non-injured skin, and after a few minutes, it splits in the layers of skin, and it's like a bread and butter sandwich. And those cells that are normally replacing your surface all the time are being harvested. They're being harvested and filtered out into a suspension, ready to spray onto the wound. So we're taking cells from a non-injured part and we're putting them on an injured part. And we're changing the goalposts. Because these cells are programmed for regeneration, not for repair. It doesn't work in everybody. Works 80% of the time in 80% of the people. We use it with traditional technology as well. But it's an indication that you can start to move the goalposts. But then you've got to finish the job off. You've got to work out how they organize on the surface to go from the spray to skin. And that's what is so exquisite, the fact that you can actually heal your cells. So when we have someone who has had a cup of coffee spilt down the chest in the 1990s as opposed to the 1980s, this is what we see as a result of spraying the cells on in order to get the best possible outcome. Changing the goalposts. Unfortunately, it doesn't happen. We can't get it right in everyone. And we try to understand why some people work well and others don't. We also look at scars long time after. This is a young lady who was involved in a flame burn. And so we do a sand and respray. Take a little bit of skin, a very small piece of skin from behind the ear, sand it all down, and respray. So we can change the phenotype. So we can change the character. We never take the scar away. You can see she's still got a scar, but we've changed the character of that scar. We've blended it with the skin around. And we've given her the opportunity to repair that surface in a regenerative way as opposed to a repair way. But what about this whole idea of self-assembly? Every one of you sitting here has got to a certain shape. From an embryo to this, we're self-assembled. If we understood that, we'd be a lot further on. And so is there information on the three-dimensional information of of our body is on our surface of our brain? This is called the homunculus. And look, the hand is big, the lips are big because we've got lots of nerves there. And we were looking and trying to work out where is it that the information comes from to drive to the normal shape instead of a scar shape. And maybe, just maybe, it's in the brain, and can we think ourselves whole? Or can we understand the changes in the brain to try and use those changes in order to drive down the regenerative path? Because if you take the tail off the axolotl and crush the nerve, it will not grow back. So the nerves are pivotal in all this. And this is a transcranial magnetic stimulation map of a young boy, as a uni student in fact, who is a much younger boy, burnt his left upper limb very badly. And there he is some years later, and this is him. And you see, compared to normal, this map is of his hand on his brain. The colours show this threshold of stimulation, and the map has changed. So we can see many years later, his appreciation of the brain of his left hand is changed. Can we actually change that back? And that's a work in progress as we're doing biofeedback training. So in order to heal, as we go through our car wash, we need the source of cells capable of differentiation. We need a framework. We need the self-organizing mechanism. Is that the nervous system? We don't know yet. And we need the three-dimensional spatial information. It can't be solely, it's got to be in the genes, but it can't be solely in the genes. What expresses the phenotype of that cell in that space. And so is that guided by three-dimensional spatial information elsewhere, and is it the brain? We don't know yet. So when we look at someone who has had an 80% burn, his burns are all his legs as well, his back isn't, this is from a motorbike accident, we do the very best we can on the day. We're thinking about going through the car wash, even though we haven't got it yet. Because one day, we will be automated. We will know, I know looking at him, that that is a serious burn. See, he has got a sclerotomy here. It's a split in the skin, so he's allowing him to breathe. We know we need to cover that, in order to get his, in order for him to survive. Unless we cover, he will not survive because infection will take hold. And over him here, you see the cells are all sprayed over his chest here, and a skin graft there, and then a biosynthetic membrane of collagen and silicon holding him all together like a pseudo skin until he heals underneath. So there's an awful lot of technology there right here, right now. But I'd have to say, it's not enough, it's not good enough, we've got a long way to go. And the only way we will get there is by working together and working collaboratively, engaging lots of different areas of science. Because what I think is really important is I work on the coalface, I see suffering every day, I see people whose lives are changed in an instant. And it's my privilege, because of all my education and training, to be able to do something about that most of the time. But that's not that's the starting point, that's not the end game. That's learning every day, learning from today's experience to make sure tomorrow is better. Always driving to understand what's going on around so I can harness that technology and deliver a better outcome to that particular patient at that particular time. So, as I say, there of all of us in the operating room, there is a patient in the middle there. But it is, at this point, very labor intensive. Surviving a burn is a very hard business. And research, science, technology gives us innovative solutions to make sure that the quality of that outcome is worth the pain of survival. And I think I'd also like you to think about this as we're going forward. I am absolutely 100% convinced that tomorrow will be better. But it's something that is hard. Change is hard. So I'm going to read this to you. The mind likes a strange idea as little as the body likes a strange protein and resists it with similar energy. How many asthmatics? Yeah, there's got to be at least 10% in the room, I would think. But yep. You know what that feels like. It would be not too fanciful to say that a new idea is the most quickly acting antigen known to science. Isn't that fascinating? We're engaging in science, in asking questions, in finding answers, but when we get a new idea, we go, whoa, hey, hang on a minute. Is this world flat? I'm not sure about this. If we watch ourselves honestly, we shall often find we've begun to argue against a new idea before it's even been completely stated. Open your minds, take your blinkers off, don't believe everything you hear, only half of what you see, and believe in yourself and believe in your ideas have worth. Because that's the way we will get tomorrow a better place. Thank you.
Fantastic. Thank you very much, Dr. Wood. Now we're going to cross for some questions, and we're going to be crossing to Charles Darwin University, then to Katoomba High School, and then to Balgowlah Boys Campus. But just before we do, for all of those people who are following our internet stream of this event, if you would like to ask a question of Dr. Wood, you can send your question into the following email address, which is questions@questacon.edu.au. questions@questacon.edu.au, and we'll endeavour to get some of those questions answered. So, Charles Darwin Uni, can you unmute your microphone and have someone ask a question? Perhaps not ready just yet. No? Okay. Let's cross to Katoomba High School. In the meantime, I know that there's some medical students in the lecture theatre there at Charles Darwin, so get your thinking caps on. Okay, Katoomba, can you unmute your microphone and ask us a question?
Yeah, good. Do you have to have different cells for different areas of the body?
Yes. The question that you didn't hear is, do you have different cells for different areas on the body? And I think that's a really insightful question. Traditionally, when we had skin graft donor sites, which is our traditional way, we take a shaving off the thighs because they're easy to harvest, if they're not burnt, of course, and we move that skin around the body. And it's clear many years later that you can see it. It's a different character. It's a different color, for example, if you put it on a face. And certainly, it would be very different if you put it on the palm of the hand. So wherever possible in a burn, when we harvesting the skin cells or harvesting our skin grafts, we will try and match the site. For example, I had a little child who had 4 fingers in a treadmill a few weeks ago. Treadmills are bad news for small children, okay? Never let them go without supervision. And so I took the skin off the sole of the foot to give the most appropriate repair on the palm of the hand. So yes, skin cells like the place they came from. They've gone too far from the stem cell all the way down the track to then come back and move down another alley. So the match gives you a better quality finish. So thank you, that's a very important point. Thank you.
Fantastic, good question there. And let's go to Balgowlah Boys College in New South Wales. If you can unmute your microphone.
I was wondering when this technique was first developed.
The technique of skin cells was first developed in the late 1970s. Guys called Reinwald and Colin Green in Boston, in MIT, developed a technique of growing this keratinocytes. The keratinocytes are the waterproof layer of the skin. And they developed a technique so that they could actually grow those skin cells into sheets. And so that was my starting point then in 1990. We grew the cells into sheets, and in our lab, when we established our lab in 93, that was the first thing we did. But those sheets had already got to the point where they changed in character. As the cells become a sheet, the proteins on their surface change. And they start to differentiate into the multi-layered keratin-producing cells. And they're very hard to anchor onto the surface. It's like you've pushed them a bit too far down the track. But at the time, we were very much skin grafters, and we wanted to put a sheet on. So as we started to understand the character of the cells, if we want them to stick and to migrate across the surface, we had to take them earlier and earlier. And so our technique's all about immature cells, cells that are just released from their constraints of each other and knocked back down that sort of pathway so they can go again. So the techniques really were first used, cultured skin cells were first used in 1982 in Boston. But it's taken a long time to get things better, and it's still a work in progress. Thank you. Thank you.
Okay, thanks for that question. Let's go to our live audience now. If there's someone in the audience here at Questacon.
That's just one in the centre there.
In the centre. There we are.
So you may wonder what we're doing here, but Burns First Aid is a really, Burns First Aid is a really important thing. So I'm going to cook some asparagus to demonstrate Burns First Aid. Well, why are you asking me questions? Sorry? I heard a voice.
Good afternoon, Dr. Wood.
Hi.
On behalf of our senior biology class, I was wondering, were you envisioning any application of your spray-on skin technology to encompass other types of specialized cells?
That's, again, a very interesting question. Can we use cells of different body types? My brother is the professor in orthopedics in Perth, and they use a lot of a lot of cartilage cells. And so their technology of taking a little bit of cartilage from a knee joint, usually, and growing those cells and replacing it back in to cover the arthritic area is something, again, that's been running parallel for quite some time. Similar but not the same. So the answer to the question is yes, and there's other people looking at different cells. Fat cells have been used as actually source of more immature cells, interestingly. And then there's work in Melbourne where they're using those fat cells to actually produce mounds that could be used in breast reconstruction. in the future. Liver cells, an artificial liver is something that they use in China, is well advanced in their technology there. Again, using the liver cells to try and in culture as like a kidney machine, you know, where the blood comes out and goes through a dialysis machine and goes back into the person if they've got kidney failure. A similar sort of thing for liver failure. So there's a lot of techniques sort of building around the world, whether it's in stem cells or in specific tissue cells, that are actually starting to look differently at this whole issue of regenerative medicine. So it's a very exciting field.
Thank you.
One more live question.
So yeah, someone.
Down the front.
Hi, I'm Caitlin. I'm from Bergman Anglican School and I'm studying Year 12 in biology. And I was just wondering, if the burn actually goes past the skin and there's damage underneath, do you still treat it in a similar way? Can you still use that, or is there something else you do?
Well, the deeper the burn wound is, the more complicated it is, and the higher your complication rate. The higher incidence of issues of infection, because it takes longer to heal. So as we get down into the deeper layers, what we use there is either traditional skin grafts with the cells, or we use a thing called Integra. And Integra is a collagen and glycosaminoglycans construct that was actually developed parallel to the skin cell development in the US, in Boston, in MIT. And this Integra is actually fascinating. We put it on the wound, and it causes tissue-guided regeneration of the deeper layers of the skin. So what happens is the skin, you remove all the deep tissue that is damaged, you put Integra down, and for 3 weeks, cells grow into it, and they express themselves the appropriate phenotype for dermis. And in this histology, you can only tell it's not real dermis because there's no hair and sweat glands yet. And so this whole concept of tissue-guided regeneration is really very powerful. After about 3 weeks, we take a silicone layer off and then we put the epidermal layers on with our skin grafts and our cells. And so yes, it is more complicated, and yes, we do need layers. Can you survive without it? Yes. But as one of my great mates, the American burn surgeon, says, is dermis, that's the deeper layers of skin. Dermis gives you the quality of life. Epidermis, the waterproof layer, gives you life. If you're not waterproof, you will not survive. So the epidermis is life, but dermis gives you the wear and tear, the elasticity. That is quality of life. And that's what we strive for.
How's your water boiling?
Our water's boiling very well. Now, burns first aid is really, really important, because you can actually influence the scar that is worn for life by many, many people. By many people, I mean, understanding first aid. I should take a step back. 2005, I was given a privilege of being Australian of the Year, and I was asked, what is it that I want to share with Australia? And I've seen basic science make a difference in people. And I realized that unless people took responsibility for their own health, education, and wellness, we wouldn't have the health system in the future the way we have enjoyed it. So we have to take our personal responsibility, and part of that is learning about things like first aid. So, for example, if you see a small child tip a cup of coffee down the chest, you remove the clothes, you sit the child on the mum's lap, and you cool the wound with water, clean water, between 15 and 18 degrees for 20 minutes, you will reduce that burn wound by 80%. That changes a child from a scald that requires surgery and pressure garments for 2 years to one that will heal, alternatively heal with scarring and require reconstructive surgery at 16 when the person wants to go to the school ball, So it's often down the front of the chest. So you will actually make a difference to the health budget by knowing burns first aid. So therefore, what we do is we cool the burn wound. Cool the wound, because if I put this one here and let it keep, let it keep going, I'm not sure I've cooked it long enough. And this one is going to go in cool running water. Now I'll turn this off. Is that right? Oops, I'll turn it up. No, I'll turn it off. Ooh. And if it all goes according to plan, thank you, this will be all floppy. Okay, it's all floppy. And it's hot. It's hot in my hands and it's continuing to cook. This fellow, on the other hand, should snap. It's cooled down. And it's cool on my hands. So you've stopped the burning process. So when you think about, oh, will I do any damage? The answer is no. You remove the clothes. If the skin comes with it, it was always going to. Things like belts retain a lot of heat. Get those off. And then cool the wound. The difference is floppy, continued burning, till you've stopped the burning process. And there's very good science that 80% reduction in scald injuries is the most, in children is the most, but it's effective in all burns. We always say, warm the patient, cool the burn, and you will change that scar that person wears for life. By knowing burns first aid, you will change the health budget. And that's going to be important in my next part of my presentation.
Excellent.
So here we go. One of the things I've been asked a lot about is what happens in disaster situations. And the reason I went through the burns first aid in quite some depth is because I noticed when we were in the situation of treating patients coming from the Bali bombing that those guys who did very well had sort of cooled their burn wounds in swimming pools, had done really innovative first aid. And you could see it had made a difference. And it became a big issue for me, and it remains a big issue. I think all of you should be taught first aid before you leave school in year 10. And I think everybody in this country should learn not burns first aid, but first aid. You should be able to stop the bleeding, start the heart, and cool a burn at least. Because I've given awards out to 3 young year 12 West Australians who were on levers when the 4th one of their group dropped dead at their feet. 11 o'clock in the morning, they'd had a big night, as you can imagine, at levers, and they'd all gone for a swim, and he came out of the water and he just arrested. They were on the far side of Rottnest. Any of you know WA? Rottnest Island is 20 k's off land. It's about 19 k's long. And they kept him going with the external cardiac massage and respiratory support for 45, 50 minutes. They got him evac, he went into ICU, and he survived. He had a very unusual heart block, and he was able to have that little bit of wiring in his heart ablated. Very simple procedure, but he hadn't known he'd got that congenital defect until that point in time. So a year later, I gave those 3 kids an award with the mate whose life they'd saved. Really powerful, it really matters. But so first aid matters, and it was brought home to me because I saw what putting a plastic carrier bag over an open chest wound and stabilising it so somebody can breathe is pretty innovative for young folks to think about doing. So my whole approach to first aid is everybody, all the time, take it as part of this responsibility and part of actually understanding that we're all part of the health system. So I just thought I'd quickly look at comparing. Oops, I'm sorry, I'm really trigger happy with this. Comparing Bali and Ashmore Reef. Bali in 2002 and Ashmore Reef in 2009. Over my 20 years as a burn surgeon, I've been involved in 14 mass casualties. These 2 are by far the biggest. When 15% of your annual workload comes in a day, it kind of tests the system. And so we have spent a lot of time trying to work out how we can do things. This is the situation in the Ashmore Reef offshore when the boat blew up. This is the situation in the Sari Club in Bali. Different environments, clearly. Sorry, trigger happy again. Sorry, okay. Back one. Oh, sorry, I think I've done it now. No, sorry. So this is, sorry. Oh, right. I think that's where I think it's where I want to be. I'll be here. Yeah. So in the situation in Bali, we have got difficulties with no initial first aid or innovative first aid when they found swimming pools, etc. Difficulty with fluid resuscitation, pain relief. Escharotomies, I showed you across the chest here, allows that man to breathe. Difficulty, tight. Burns are tight. They tighten up. Restrict your breathing, restrict your blood supply. Dressings were difficult in all sorts of ways. Then we have the situation with Ashmore Reef. We had on site the Navy with support, as you can see here, being dropped into the naval ships with intravenous fluids, bandages, as they commandeered a rig in the Timor Sea. Every one of those patients had a young able seaman doing extraordinary work to keep them, one, alive and improve the quality of their survival, as you can see in this environment where they're the makeshift field hospital. So we've got the Bali patients, were some very big burns, but most small. In the Ashmore Reef, 2/3 were over 20% of their body surface area burnt. So not directly comparable. The injuries are different, and I think that's something that we see as now the differences in the disasters around the world that are happening. You must understand that the Australia has a great medical response teams that are all guided by the needs of the disaster. A tsunami is associated with near drowning, orthopedic injuries because of the debris and that causing wounds and fractures. Certainly, burns injuries, they're obvious in the explosions. Then the response teams are adjusted accordingly. So in Bali, there was blast injuries, all eardrums are blown out, vascular trauma because of the blast, lots of fractures and shrapnel, lots of debris. In the Ashmore, there was near drowning, saltwater immersion causing infection, and infective contaminations in those circumstances. Infection, I said right at the beginning, was one of our biggest problems. And here we've got all sorts of different microbiology, but extending related to the environment of where it happened. In the water, where the water doesn't fall below 15 degrees, there's some really interesting and virulent bugs. And in Bali, there's lots of multi-resistant. You see this word coming up. So you have to understand the local microbiology to understand how best to treat the person. It's very important. We need to know that we understand that it's much better if we can do all of the operation. In the first operation, that's our aim. So with Ashmore Reef, we have 19 patients with one surgical procedure. But in Bali, you can see a number. One person had 9 and then died. So we always try and get this line, the biggest line. And here we had no deaths in the Ashmore Reef, but we had a number, one had 4 procedures. So always driving to get that wound closed as quickly as possible. How long did they stay? At 2 weeks, most people left in Bali, and the same at Ashmore Reef. So 3 weeks is a standard kind of procedure time for us at this stage. One of the things I wanted to bring home to you is that it's all about looking at what you've done, carefully appraising what you've done, and working out how to do better. That's kind of a bit of a broken record. And so we collect clinical indicators, data on all these things, and we've collected that for nearly 15 years. So when I see these Ashmore Reef patients, I can tell you that they were as good as, if not better than, our metropolitan patients matched for the same size of burn, with the exception of 2 things. This was the escharotomies, and we changed our practice as a result of this, and we were able to do better. And this is the antimicrobial dressings, and we changed our practice as a result of this. Not because this isn't good enough, but that is certainly not good enough at all when we're looking at infection being our biggest problem. So we've changed our statewide policy on how we can, and actually facilitated silver dressings being in every place so that we can actually use them to actually change that. So I've used this just to show you that you can't just go, oh, we did the job and we walk away. And again, looking at all the different things, the psychological, the physiological, the weight, the itch, the pain, fitness, all these different things are measured all the way along to understand how can we actually change this science and make a difference to the person and know what we're doing. So that was a very rapid run through 2 really significant disasters, but it's absolutely important to know that disaster planning is all about planning. And life planning is all about planning. You can wander through going, oh yeah, it'll all be right in the night, but if you think about it first, it's an awful lot easier. And the future of human society is unpredictable because it's complex. But complexity makes it exciting. It doesn't mean you can't understand it. Okay? And I'll leave you with this image because it always moves me. This is January, Australia Day, 2003. And every flare you see there indicates one person who didn't come home from their holiday in Bali. The majority of them were very young folks who went over and never came home. And so this whole discussion today has been about engagement, engaging in science and engaging in your intellect in making things better for everyone. Some folks just don't get the chance. Thank you very much.
Thank you so much, Dr. Wood. At this point in time, my victims/volunteers, we're finished with them. I'd like to bring them out onto the stage. If you girls, Brooke and Carly, could come out here, and we can see what you could do for these girls. If not, come out here. Don't be shy.
I can see myself reaching for the cold water straight away and pouring cool running water. No ice. Ice gives you frost damage on top of your burn damage, makes it worse. It might make it feel better because it goes numb. And it's painful. Oh, you're smiling? It should be pain. Yeah? Look at this as well. I have to answer one question. Will this wound heal in 10 days? After my first aid, I've poured it over your head. If this wound heals in 10 days, the chances of scarring are less than 4%. If it's not going to heal in longer, I'll be operating. I think you're better off. If you turn, you see there's areas here that look like they've managed to survive through. Because Dr. Sass pretty good at what he does, but here looks like areas that have gone punched through.
Oh, we went much more for the blister motif over there on Brooke. But give them both, please, a round of applause. And now one more. Sorry, just a sec. What now? That's no, we're in the middle. Look, look. Well, fortunately, bring them through. Yeah. There's been a bit of an accident in the cafe, and someone stupid enough to throw water into a chip fire. I'd like to introduce you to Chef Dion, who's not tremendously happy right now.
So what am I going to do? How long for? 20 minutes. What's temperature of the water? 15 to 18 degrees. Oh, has anybody got any ice blocks? No. Good. Fantastic. And this is really sore, isn't it? Yes. You can see it's a classic, you know? Really sore. And you go, a chip pan, you pick it up. No! Because the next thing you know, your shirt's on fire. Your shirt's on fire, your face has got a flame burn. And this is looking serious. It's going to start swelling soon. So what I'm going to do is see if we can get another pillow, a couple of pillows. Because if he's laying flat, this all will swell. And then he'll stop breathing. So in those patients post-Bali... You think it's going to scar? Yes. Well, let's have a think about this. And I think that's really important. Let's sit you up a little bit. Oh, that's good. That's good. That's good. That's good. Good.
Whining baby.
Oh, no, the caring profession. We'll give you some pain relief really quickly now. Because the first thing I'm going to be doing is I'm going to make sure you sit up so it doesn't swell. I'm going to put oxygen on. Oxygen delivery to that burn wound will salvage cells. I'm in salvage mode already. I'm going to put a drip in because I know that's underneath here it's going to start leaking, like leak outwards like a leaky sieve, but all leak inwards, it'll swell up. So all that water, that swelling is actually out of the circulation. So that's why we need the drips in. And as soon as I put the drip in, there you go. That's the pain relief. That's the morphine. And now I can scrub and clean it. Because I'm really, I've got all heart. Because I know that infection is the biggest problem. So I will be scrubbing and cleaning, cooling it down, to make sure that I can salvage every little bit of cell possible in there to give him the least possible scar. So it's all about salvage, and all about pain relief. And we say, cool the burn, but warm the patient. So once we've checked that there's no other injuries, we'll be putting a space blanket on. And then we'll be focusing in. But we also want to know things like, are you diabetic? Do you take drugs? Very important. Because some drugs lift your heart rate so high. I spend a lot of time trying to chase that infection which lifts your heart rate really high. And it's not that. Very important. Could kill people. You know? So all knowing everything about you is where I go next. So I go airway, breathing, circulation, focus on the wound, establish my oxygen, my drips, pain relief, take my bloods, and then get to know this person. Because this person's going to be the sort of person, looking at these wounds, that I will know for 5 years, minimum. And if you were 5, you'd be sick of seeing me, because I've now been in this game long enough to see kids who were burnt as babies coming through as adolescents, reconstructive work into the adult hospital. Yeah, so they get sick of seeing me. But because we can actually push those goalposts and keep pushing them to get the very best possible outcome. Excellent. Thank you. I hope it doesn't hurt too much later in the day when the morphine wears off.
Thank you, Dr. Wood. Would you like to come take a seat? We're just going to move now to some more questions from the far end, and we've actually had some people email in some as well.
Yes, we have indeed. We've got a question from Hay War Memorial Public School, and they're wondering both what is the worst type of burn to treat, but in reference to you saying that the skin graft works about 80% of the time, what's the cause of the failure of the other 20% of the time?
Well, take the second question first. Why does skin grafts not always work all the time? And the factors of the whole person, if they're have a diabetic, or they're nutritionally compromised, or drugs and alcohol, all those things actually make a difference to people's healing capacity and their infection risk, as well as steroids and other drugs as well. So we have to optimize people the best we can, and nutrition is a really important part of what we do. And so we start feeding people with high protein and lots of trace elements and vitamins early on, and we treat people to reduce the risk of infection straight away. But we can't control everything all the time. And so that's when their escape of control is when we have to go back and do the operation again. And so that's why you see most of the time we can do this in one operation. And if you look at all the results of our surgical procedures in Western Australia, 94% have one operation. But that means 6% we can do better. And that 6% are the ones that we really have to batten down and work hard on. But in that 94%, there'll be people who will not have a second operation, but will take a little bit of a long time to heal, because their operation will almost be right. Not good, not so bad that we have to do another one, but they're in that borderline. And that's why we say 80% of the time we'll get crisp healing in one hit.
Okay.
And
did you need to answer the second part of that?
Yes,
Yeah.
I think the second part was, sorry?
Just what is the worst type of
Which is the first part, yes.
Sorry.
And that's electrical burns. Flame burns and scald burns are the commonest. In children, more scalds, then it's contact burns, like the friction, like fronts of stoves and things like that, hot embers as they walk through campfires and things. In adults, it's flame with scald secondary, but fortunately, electrical burns and chemical burns are small. I've recently seen the worst burn I've ever seen with sulfuric acid, and by the time they got to me, which was within 4 hours of injury, one of the legs was not salvageable of this person. So, I mean, in 20 years, I'd not seen anything so aggressive. So, and that was with absolutely tip-top first aid, absolutely everything that was done from the point of injury all the way through could not have been better. Yet that acid was a nasty beast. So I would say when you start to get chemicals, you've got to be really careful. And electrical it's difficult because you'll see an entry point, small, an exit point, big, and there's a lot of damage in between that sometimes you take ages to find. And so that's why that's complicated.
Okay, thank you. Good question there from Hay. We're going to cross shortly to Coringal High School to get a question, and also back to Charles Darwin University. But in the meantime, while they get ready, is there a question in our live audience that we can get a microphone to you? We'll take that one.
Hi, my name's Charlotte and I'm in Year 11 at Marucci College. I'm just wondering, what made you want to be a burns specialist?
I started as, when I went to school, from school to university, I obviously went to med school, and I wanted to be a surgeon pretty well straight away. And within surgery, for me, it was a very interesting time. I went to med school in 1975, before you even a thought. And so they were doing a lot of interesting and innovative plastic surgery. It was the time when microsurgery was really hitting its straps, where we could take things like, you take the muscle from the back, based on the blood vessels and wrap it around a lower leg of a young man in a motor vehicle accident and salvage the leg by moving things around the body, replanting severed digits and hands and things like that. So it's a very exciting specialty, and I was an observer of that. And I realized to be a surgeon as a female, I had to make myself stand out, and I had to get noticed. And so I started pestering if I could do some research with them, because I knew they ran in the St Thomas Hospital Medical School an aggressive research program looking at anatomical dissections. And I was an anatomy freak. I loved anatomy. And so the whole idea of going in and dissecting in order to understand the vascular anatomy for microsurgery was sad but true, very exciting. And so I was like, oh, yeah, pick me. And so that's where I started my interest in plastic surgery. And then as I got through, plastic surgery is a massive spectrum. Extreme rebuild, extreme makeover. We use the same techniques. My colleagues and I learned from all the way along that spectrum. I just personally chose the extreme rebuild end. It was the blend of the intensive care, the multidisciplinary side of things, and that understanding that this is a really hard nut to crack. Solving the problem of burn scars has a massive flow-on effect into lots of other things. And maybe as a little bit of competitive nature, I thought, that's tough. And it's kind of drew me in. To see people taking on that level of suffering and coming and surviving, it was inspiring too, I'd have to say. People are just astonishing what they can cope with. And so all that, you put all that together, and I got sucked down that burns specialist route. By 85, I was half a leg, so my toe was kind of up to here. And by 93, I was in, all the way up, over my head. Thank you.
Okay, we've got another question from the live audience.
Hi, my name's Tanya Cobden, and I'm from Bergman Year 12. And I kind of have a two-part question. And I was wondering, does your research kind of relate to people with skin cancer? So they've got damaged skin cells as well, and does that come as part of that, their treatment, perhaps in the future? And I think as an aspect of that, how acknowledged has your research been internationally in the scientific community as well?
Well, the first question, is it related to skin cancer, or are there treatments utilizable in skin cancer, I guess? And I think it's a fascinating sort of two-part within itself. I was brought up with the understanding that burn injury increased your risk of skin cancer, and I figured if anywhere in the world we could show that, it would be Australia, because Australians have the highest incidence of skin cancer, and we're still looking. Having said that, we have a data linkage project that's funded by the NH and MRC, linking data with our cancer databases with our burns database. That's come about because we had a boy in 2003 who was 8 years old, and he had an 80% burn, and he did fantastically well. We all thought we'd done a great job, and he was an amazing survivor. But he came back to see us 18 months later, and he had a very large mass in his liver, and he died as an 11-year-old with a very rare cancer. And I spent a lot of time going around the world asking my colleagues if they'd seen this kind of thing. And so now we're looking to see the links between cancer and burn and other trauma, because I think there's more to this than meets the eye, and the changes in the immune system around trauma. And that's something that is, we're kind of at the first page of the first chapter on the first line in understanding that whole thing, spectrum. Can we use the technology in skin cancer? Yes, I have. Some people have so many skin cancers you can't use traditional therapies, and as a last ditch, in desperation, they'll go, oh, Fiona, can you do anything? And I have shaved completely whole legs and resprayed them. It doesn't look pretty, but it is functional in a position where you've nowhere else to go. In the future, when our technology is better, then yes, I think it will have a place as an appropriate treatment of skin cancer. And with respect to internationally, I do a lot of my research with international collaborators in Boston and in Wake Forest in North Carolina. They have the biggest grant on the planet for the kind of stuff we do. It's like $200 million US. And it's like, one of those, pick me. And so our group is one of the very few groups in the world that does the skin the way we do. So that's why we've ended up with the US military, because it's a US military-linked grant, looking at regeneration of their soldiers, rebuilding their soldiers. And so we have our clinical trials funded by the US military in the US. Yeah, so there's all those kind of collaborations that have been built, and in Europe as well. So and now in China, and so it's a small field. It's a group that knows each other quite well, and we're kind of these pervasive problem solvers who find scientists working on pieces of our jigsaw, and we go and seek them out and bring them into the sort of team, whether that be in Quebec or in Montpellier or wherever you may be hiding, we will find you. Yeah, and that's the sort of group of clinicians. Yeah.
Thanks, Fiona. We're aware that our hour is coming to an end very probably around about now. But if schools can stay on the line, we're going to have a little bit more interaction going on the stage here. We're now going to cross to Kringle to try and get a question in before they do have to leave our conference. Kringle, can you unmute your microphone and ask a question?
I'm Andrew, Year 11 at Kringle High. I was wondering how much it costs to make one of those skin sheet things.
The skin kit.
Yeah.
Well, the cost of medical devices is a really, I've been educated in, been involved in the development and the sort of commercialization of all this. We commercialized the whole, that kit in order to fund our research going down the track. And so that's now, as I say, going on into other countries around the world. And the cost to us in where we've started is it's not for profit, because we use it because it's ours, if you like. The cost is different in different countries, depending on their local environment. And the cost is as a result of the medical grade plastic we have to use is tested plastic, not your standard plastic, because that puts a factor of 10 on it. It's sterilized. Everything has to be double checked and triple checked with respect to the enzyme, the filters, the syringes, and everything. So it starts to come somewhere around the $1,000 mark to use that kit. And so then you think, well, that's a lot of money for one kit. But to actually have one day in hospital in a burns unit is nearer $2,000 for one day. And to run a laboratory to grow the skin cells is vastly much more complex and costly, because the controls around taking skin, which is where we started, took the skin from the person into the laboratory, worked on it for 5 to 10 days, and then brought it back. Those days in the laboratory are seriously expensive because of the checks and balances around that. So the drive for us to make this kit was all around affordability so that it could be utilized. So it's, as I say, around about $1,000 or thereabouts, but that is on medical technology, medical devices, that's the cheap expensive.
Fantastic. And if we can just cross to Charles Darwin University and see if someone has some questions or interaction for Dr. Wood. If you can unmute your microphone.
Hi, my name's Annie. I'm an occupational therapist. I just wanted to ask about, in simplistic terms, scarring is a proliferation of collagen cells with the epidermis and epidermis layers and the regeneration that you're using and the technology. How do you prevent that proliferation of the collagen cells that forms the scar?
The question is, how do we manipulate the collagen production that's due to the combination? Really comes from fibroblasts. The collagen comes from the fibroblasts, and the fibroblasts are in the dermis of the skin. Many years ago, we thought that the scar phenomena was dermal only, with the deeper layers of the skin. But there's a lot of evidence now, like I mentioned the guy from Quebec, who's done a lot of work on understanding that the keratinocyte, this epidermal cell, actually influences the expression of the underlying fibroblast, which influences the collagen production. So by introducing cells that are keratinocytes, the epidermal cells that are programmed to regenerate normal skin as opposed to scar, then they influence the fibroblast, which and then in turn influences the collagen. And not only the collagen absolute production and degradation, but the character as well. So there's an awful lot we don't understand about the nuances of that. But I think one of the issues is controlling the inflammation and by rapid seal of the surface. And also, we do a lot of massage, and I think the self-organization, the maturity is related to the nervous system as well. I know that's sort of a big answer in a very short time, but I hope that helps.
Is there another question from Charles Darwin just before we move on and to the last sequence?
Hi there, Dr. Woods. I've just got a question. Mine's in relation to major incidents such as Ashmore Reef. We're worried about airway burns. Is there any indication for less aggressive fluid resuscitation in patients who don't have to be able to...
We're having a bit of problem with your audio just at the moment. Can we cross back to you for that question, and we will continue because that's coming through a little bit garbled, I'm afraid. Sorry about that.
Okay, so Dr. Wood, I have a few questions for you, and hopefully we get to know you a little bit more on a personal level. Now, I believe you have 6 children.
Yep.
How do you manage your workload and taking care of such a large family?
Well, sometimes I think that's the hardest question to answer because I've just been really lucky. The kids are great, but sometimes they do turn around and say to my husband and myself, didn't you understand that child labour was abolished in Victorian times? And so they have had an element of that camaraderie and looking after each other that they sometimes will push back on. Because with they move as a pack. And my youngest left school just recently, last year, and she did not like the last year of school. She goes, "What? This is just not on. I'm here by myself. Where is everyone?" I said, "Well, it's always going to happen, you know." So they have. I think I've been very fortunate that they're very close, and that certainly has been pivotal in their upbringing each other. And I think that was a conscious decision because we knew we would always work, and I knew they'd always need each other.
Excellent. Now, throughout your career, have you been inspired by anyone?
Oh gosh, yes, lots and lots of people. I think I always put inspiration into sort of groups, and my mum and dad have to go first on the list, and they taught me the value of hard work. It may sound boring, but there is absolutely no substitute for hard work. You want anything, you work hard enough, you'll get it. And it's really, I say, straight up and down. It's not rocket science, but my goodness, they taught me the value of hard work. They left school at 13 and 14 and worked hard so that the 4 of us had an education. And the whole deal was you get an education, so when you get up in the morning, you enjoy what you do. And that was, they didn't care what we did, but when you get up in the morning, you've got the choice to do something you enjoy. And that was very powerful. Some of the teachers I've had, I've got the images in my mind. Some were kind of eccentric and crazy and really cool. So my chemistry teacher at school was a seriously mad professor, kind with a long bit Harry Potter kind of looking person, like Hogwarts type, and he was fantastic. And then at university, some of the surgeons that I've worked for, and then the patients. You know, the patients are just inspiring. You know, and I think of people like the young boy who died, and I think, whoa, we can't let that go unnoticed because he has inspired me to chase something, to chase it, to make a difference to others. Yeah, so lots of people.
Unfortunately, we're under a time constraint, but I thought, as the last question, is there any advice you can give to students out there who would like to take up a career in science or medicine?
I think one of the things is do it. And I think I guess I've touched on this as I went through today is, you know, believe in yourself, believe in your ideas. I think everybody's unique and special. Everybody's got a gift to give, and all too often we don't see it in ourselves, and we sure don't let other people express their gifts. I ask a lot of school kids, a bit younger than you, I'm afraid, have you ever done anything less than your best to make everybody around you feel more comfortable? And they all can give me examples, and I think that's really sad. And I go, when have you done something absolutely your best, in the raw, and everybody's come with them? You think I'm mad. You all got something to give. And unless you have the courage to stand up and say, yeah, I can do this, and yeah, you can help me, and I can help you do what you do best, then we're going to just rumble along, mediocre. But if we want to actually really change things, we have to believe in ourselves as people, believe in the uniqueness of each and every one of us, And there's no substitute for hard work. That's the boring bit. It really is. You know, when you've done a job and you've done it well, take the time to enjoy that. Because there is a joy in work for work's sake. A heavy sell, I know, but there is. Take the time to feel it and think, yes, I can do that. I did that well. And maybe tomorrow I'll do it better.
Excellent. Thank you so much, Dr. Wood. Would you like, we're just going to go up here to say
Right.
goodbye to the
To
far
Darwin.
end.
Yeah.
Do you want to come through here?
Come and join us. Okay, fantastic. It's been great to have you here, Dr.
been
Wood.
lovely to be here. Thank you.
It went so fast, we've gone over time, and I do apologise that to the schools who are both here and need to get their buses, but we're going to wrap it up right now, but also to the remote schools, and if we didn't get to your questions, I really do apologise for that. But feel free to email to us at questions@Questacon, and we'll see what we can do.
Yes, I can email.
Yes, exactly. Once again, we'd like to thank our partners, the people who made it possible to bring Dr. Wood here to Canberra and then around Australia, CSIRO Discovery, Inspiring Australia, ARNet and Questacon.
And thank you to our awesome audience, both the far end and, of course, our huge live audience. And can we please give Dr. Fiona Wood one last
Farewell to the far end, and we'll see you next time. Lots of video conferences coming from Questacon later this year. Good afternoon.